Good evening, everyone. This is Jae-eun and I am clinical professor at Seoul National University Dental Hospital, Department of Periodontology. Welcome to Live Surgery supported by Dentium. Today's operator is Dr. Jang Geun-young. Dr. Jang and I completed my periodontal residency at Seoul National University Dental Hospital about 20 years ago. The patient is female. She is 76 years old, quite old. She shows severe alveolar bone resorption in the left mandibular posterior area, and at the same time, the opposing left maxillary posterior implants are over-erupted. So the question is, how did this situation happen? During history taking, we learned that the patient had used implants for more than 20 years. This is a 2023 article in Periodontology 2000 introduced the minimally invasive vertical ridge augmentation technique. There is limited evidence that aggressively augmented vertical bone remains stable in long term. Another recent study showed that using only xenograft and a resorbable collagen membrane without fixation pins, stable vertical bone was maintained up to 7 years. Some cases achieved more than 5 millimeters of vertical gain, so theoretically, if we can achieve a similar result to today's surgery, the long-term prognosis should be acceptable in today's patient too. As you can see in the radiograph, these pictures are from the article I just showed you. The bone was not aggressively augmented vertically. Instead, only the minimal required height was gained and short implants were placed. This is the current trend. Now we confirm that vertical GVR can be achieved using resorbable collagen membranes combined with particulated bone substitute, yielding significant vertical bone gain and long-term stability. Osteon 3, collagen and osteogeno will be applied. He did the cortical perforation on the surgery site. I will show you the Dr. Zhang's own authentic technique today, which he named the mango beans technique. This is a mango bingsu. Bingsu is a famous dessert in Korea. It's a shaved ice with chopped fruit on top. He said that he got inspiration from this. First, use the xenograft powder like ice for base development. After that, place some blocks of osteon 3 collagen or osteon geno collagen on the top, like mango pieces. In this technique, the barrier membrane acts like a bowl, and this helps the graft material stably remain at the site. By doing this, we can easily make an overbuilt shape. Maintaining the graft material in right shape, carefully place the barrier membrane on the site and make a suture with a primary closure. Comparing it with the use of titanium mesh or non-resorbable membrane like DPTFE membrane, it is much easier and simpler and reduces risk for the complication. Of course, it's much more comfortable for the patient. Here is the result of the surgery. The regeneration of the upper area is stable. You can check it on the tomographic image here. Thanks to the newly developed bone grafting material like osteon 3 collagen or osteogeno collagen, this surgery became so easy and simple. Let's see the clinical photos of this case. The most coronal part of the grafted bone is osteon 3 collagen, and it can be easily collapsed by the tension of the flap. But by mango beans technique, the regeneration of the uppermost area is very stable and successful. You can check it at the result of this clinical photo. Osteon 3 collagen is mainly used for the contour augmentation in this similar case, but we will use other collagenated grafts today. Today, Dr. Zhang will use osteogeno collagen and osteogeno for mango beans technique. The important point of the mango beans technique is to maintain the dome shape in the uppermost area. To do that, you should not manipulate this area too much. You don't need to make actual dome shape. This will happen naturally as it is pressed during the suture process. So the paradigm change is reflected in the current process of GBR. If I define the GBR techniques in the past as strict GBR, I would say the techniques we use now is simple GBR. There have been changes in biomaterial and graft material and techniques to be adapted for simple GBR. In case of strict GBR, autogenous bone graft with titanium mesh or EPTF membrane are used to make sufficient volume for newborn regeneration. But now you can get enough newborn regeneration by minimal invasive GBR technique, and Dr. Zhang is ready to show you the real case. When I heard that 2 weeks ago that Dr. Zhang would perform this surgery at this patient, honestly, I wanted to stop him. But he said that he wanted to fulfill the patient wish. Now we are about to begin. Let's wish him good luck and watch the live surgery together. The vertical ridge augmentation follows the same general sequences as GBR, but each step is more difficult. Today, I will focus on explaining those difficult points in the clinical procedure. The first step is incision, and Dr. Zhang is making incision at the surgical field. Although it is hard to see clearly in this live surgery, this is the incision design that Dr. Zhang showed me before. The mental lobe goes through very close to the alveolar ridge, so he modified the incision design to avoid the damage of the mental lobe. He is using number 12 blade to make incision to the number 35 tooth distal aspect. And as you can see, he's making horizontal incision from distal side of number 35 tooth to about 38 tooth area. The interesting thing is that the incision curves gently to the third molar area without any vertical incision at distal aspect of the surgical field, forming a smooth, continuous curve. Dr. Zhang said that the advantage of this approach is that the incision line is located in keratinized tissue, which improves flap stability. In cases with severe bone resorption like this case, if the incision does not reach the bone clearly, the flap can be tear during the elevation, and that would be completely compromise the surgery result. Dr. Zhang starts flap elevation, begins very slowly, and Dr. Zhang changes, I think he changes number 15 blade to a new one to elevate flap clearly without trauma or tearing of the flap. He alternates between a number 15 blade and a peristyle elevator to elevation of the flap. Usually the elevation starts from the major corner of the number 35 tooth because this area is the safest point. Now the flap elevation is finished, and next time the implant will be placed. At the number 35 site, the diameter of 3.5 millimeter and length of 7 millimeter bright tissue level implant is planned. And now, as you see, Dr. Zhang is making cortical bone perforation to improve angiogenesis for newborn formation. Since the distance to the nerve is only less than 4 millimeter, he does not use high-speed drill because high-speed drill would be very risky for nerve damage. The drill using now is a 3 millimeter stopper drill that Dr. Zhang personally uses. This allows fast cortical perforation while maintaining safety. And now he starts implant drilling for the implant placement. Because of this implant concept, the drilling protocol is very simple. I think 2 steps of the drilling will be finished. He is using first drill for implant placement. Yes, this one is still first step drill. And Dr. Zhang is using second step drill now. I think this one is the final drill. After only 2 short drilling steps, the implant is placed now. It seems that the fixture has enough stability. It appears that the implant is positioned about 2 or 3 millimeter supracrestally with a slight focal inclination, just as planned. As we confirmed earlier, there is no natural lingual bony wall to support the graft material, So this is like building sandcastle on a flat surface. So maintaining the shape of the graft material is the most critical point and most difficult part of this surgery. So Dr. Zhang uses his favorite mango beans technique today. First, Dr. Zhang applied collagen membrane at lingual side, which can be a supporting wall for graft material. And then osteogenocollagen is used to gain the vertical height of residual ridge. The genograft collagen is placed in a slightly hydrated state. He does not hydrate the genograft collagen fully because as it absorbs blood, it helps with hemostasis and becomes moldable like clay. And he is making periosteal releasing incision to advance buccal flap with number 15 blade. He extends the periosteal releasing incision to the major vertical incision line. He is checking the advancement of buccal flap now. Next, osteogenoparticle graft, the particulated bovine bone graft material, is placed at the base of defect and around the osteogenocollagen. This is part of Mangoving's technique. The osteogenoparticulated graft acts like a ice. It forms a base of the grafted material. Dr. Zhang continues applying osteogenograft at the base part of the defect. A collagen membrane is temporarily placed on the lingual side, as you can see now, and the particulate bone is added now. Without this collagen membrane, the graft material would collapse into the lingual space and would never get stability. Once the graft becomes stable by absorbing blood, the xenograft collagen is shaped into a tent-like dome. Think of it as building a wide base first and then placing pillars to support a tent. He continues applying osteogenograft at the defect. As you can see now, the lingual flap is very movable, and he's applying the collagen membrane at the lingual side. Dr. Zhang prefers not to spend too much time trimming membranes, so instead he uses two large membranes, cuts them diagonally, and overlaps them like a loop. He is applying two membranes at the graft side. He is using the Dentium collagen membrane, which is more stiff than BioGuide. So you need special technique to apply the membrane on the graft material. Instead of trying to adjust the membrane too much, place the two membrane overlapped. As you can see in this video, this method can cover graft material more safely. Once the membranes are roughly positioned now, they will be stabilized by sutures. Compared to sausage technique by Dr. Istvan Urban, he fixes the membrane with pins, but this method is much simpler and does not require pin removal after the surgery. Dr. Zhang starts first suture. The first suture is a key suture, usually a horizontal metal suture. You can see that the needle is inserted very deeply from the buccal side. And this suture is a kind of horizontal metal suture to make flap everting and helps the membrane stay inside. This suture resembles a Bujo-style metal suture which stabilized both flaps and secured the membrane at the same time. Accurate placement and sufficient depth are essential to ensure adequate flap thickness on both sides. It means that the insertion point should be located far from the incision line. Check the insertion point of the needle here. Dr. Zhang is trying to locate the insertion point of the needle very far from the incision line at buccal side. If the needle goes through the flap near the incision line, the membrane cannot be secured in position. I think the insertion point locates about 10 millimeter far from the incision line. Check the flap everting and the fixation of the membrane. Okay, this one is the key suture. And I heard that Dr. Zhang prefers simple interrupted suture. So because the key suture already stabilized the flap and only thickness adjustment is needed afterward, he usually uses the simple interrupted sutures in vertical GBL case. Now he's making simple interrupted suture at horizontal incision line after the first key horizontal matrix suture. Dr. Zhang told me that he usually avoids vertical matrix sutures and prefers a simple approach even in vertical GBR case. After key suture and one or two simple interrupted sutures, the bleeding control looks quite good and the flaps are closed without tension. And he is using 50 nylon suture material. He's making additional simple interrupted suture between the horizontal matrix suture at horizontal incision line. And let's summarize the key steps in this surgery during the suture. First, a curved incision was made. Dr. Zhang avoided vertical incision at distal part. This helps the incision line located in the keratinized tissue. And second, the careful flap elevation avoided the mental nerve damage. And the 3.5 millimeter diameter and 7 millimeter length of bright tissue level implant was placed slightly supracrestally. The bright tissue level implant is very strong in structurally, so you can use 3.5 millimeter in posterior area. And cortical perforation was performed safely with 3 millimeter guide drill. And a dome-shaped graft was built using two graft materials, using osteogenocollagen and osteogeno by Mangobin's technique. And two overlapping membranes, the collagen membrane by Dentium, were placed. And sutures stabilized both membrane and flaps. Dr. Zhang first used the horizontal matrix suture, which is located deeply at buccal site, to secure the membrane, and he is using simple interrupted suture along the horizontal incision line. I want to emphasize that this case is very challenging surgery and very difficult surgery, but as you can see in this video, Dr. Zhang can do the vertical GBR in very simple and easy way. So after you watch this today's live surgery, I propose you to try the vertical GBR like this technique using collagenated graft and xenograft particle with collagen membrane. The suturing proceeds slowly while continuously checking membrane position, and the bleeding control is almost done at the surgical field. He is adding suture at the distal part of the horizontal incision line. He is checking the surgical field now. After enough periosteal releasing incision and enough dissection of lingual flap with the horizontal matrix suture, you can get tension-free closure of the flap. He is checking the surgical field now. I think Dr. Zhang will make suture at vertical incision line at medial side. I think about 20 minutes have passed since the surgery started, and the surgery is almost finished now. I think this one is the final suture. The surgery just finished. Let's check the post-operative panoramic radiograph. You can see the implant placed at number 35 site and elevated bone level here. You can see here. The implant was placed about 2 or 3 millimeter supracrestally, and the augmented ridge can be confirmed at tomographic radiograph too. The GBR, after vertical GBR, there is more than 9 millimeter and number 36 or 37 site here. So considering the resorption of the graft material or shrinkage of the graft material, Dr. Zhang will place the 7 millimeter implant after healing. And you can check the graft material around the number 35 implant fixture here. This is a clinical photo of 2 weeks after the surgery. The wound site looks very good with no dehiscence of soft tissue or no membrane exposure. So I got 2 questions about today's live surgery. The first question is, how can you avoid nerve injury to the mental nerve? At the number 35 site, the mental nerve is very close, so flap elevation must be minimal. If the flap must be opened widely, you have to make a full thickness flap to identify the location of the mental nerve. And second question is that how can the lingual flap can be retracted without tension? As you watch the live surgery video, the lingual flap was retracted without tension and it has the tension-free closure after the surgery. If the lingual flap is not released enough, the tension cannot be distributed evenly and there can be flapations during healing. Therefore, the lingual flap should be dissected up to the area above the mylohyoid ridge carefully. It is very deep. You should not make periosteal releasing incision at lingual flap because of the risk of the nerve injury. So instead of the lingual flap must be sufficiently dissected to the mylohyoid ridge to eliminate the tension during the suture. I want to emphasize again that today's surgery was very difficult and technique sensitive vertical GBR, but you can apply the same technique as Dr. Zhang did today. It is very simple and easy technique for vertical GBR, and patient discomfort will be decreased too. Thank you for watching the live surgery today, and next live surgery will be February 6th at Friday, Korea time, 7 o'clock. Thank you for watching today.